Welcome to Bunny Hugs and Mental Health, the podcast that deals with all things mental health. We talk to professionals, survivors, and loved ones about their sometimes informative, sometimes uplifting, and sometimes tragic stories. I'm your host of the show, Todd Rennebaum, advocate, recovering addict, experienced sufferer of depression and anxiety, and author of the children's book, Sometimes Daddy Cries. Hello and welcome to another episode of Bunny Hugs and Mental Health here on the Saskatchewan Podcast Network. I am Todd Rennebaum. Oh boy, am I excited. This is really great episode this week. I know I say that every week, and I'm right every week. This one's pretty juicy though, and I'll talk about it in just a sec, but first, next week, I will be speaking to a lovely lady named Emily Roberts. She has a podcast called A Sober Story Podcast. And she is a young mother. She is a young wife. She married young, had kids young, and she kind of had a hard time transitioning from a party college girl to a responsible adult. And she tells her story about drinking and kind of that transition. We talk about kind of how the alcohol companies are really targeting women these days with the wine mums and all that stuff, and how damaging that is. So stay tuned for that. And being summer, I realize that there's podcasts aren't maybe being listened to as much as they are in the winter. But if you get a chance, I really suggest you listen to the last few weeks' episodes. Last week I spoke with a young trans lady, Juniper Elvin, and talked about her last year of transitioning. She came out a year ago, and so we talked about the last year of her life and some of the mental health challenges she's faced, as well as physical and relationship and everything else. So I was going to say watch that episode, but there's nothing to watch. You can listen to it though. The week before that, I spoke with my friend Dina. She's a life coach, and we discuss the differences between thriving and surviving and what that looks like. And the week before that, I spoke to a really funny, really amazing, sweet guy, Big Daddy Taz. He has struggled with bipolar, ADHD, OCD, ABCD, EF, and G. He is a stand-up comedian, and we really hit it off great. And that's a really great interview too. So please, if you get a chance to listen to all those. Also, if you get a chance, please rate and review this podcast. I can't explain enough how important that is and how much it helps the podcast. So please, if you get a chance, do that. Now, this week, I am speaking with Dr.Sonu Gand. He is a psychiatrist. He's also a professor at the U of T, or the University of Toronto. He's a chief of psychiatry in Humber River Hospital, which is also in Toronto. And at that hospital, he's also the physician chair of their MAID team. MAID stands for Medical Assistance in Dying, or as some people call it, medical assisted suicide, or euthanasia, whatever you want to call it. Right now, it's called MAID in Canada. So throughout the interview, if you hear MAID, that's what we're talking about. Now, usually MAID is for the physically ill people that are on their way out or not getting better or getting worse. Canada in 2023, they have introduced a law that allows folks with mental illness and mental health issues to apply for MAID. And there's been a few already go through, and a few people have already passed away because of this. And it is a very controversial, very sticky subject. And I discussed this with Dr. Sonu Gand, and he makes a lot of great points. I'm telling you, you do not want to not listen to this podcast. I made that very confusing. I'm telling you, you want to listen to this episode, okay? Tell friends to listen to this. It's not only just for my own ego, but also because there's a lot of information, and it's very important that people hear this. So without further ado, I give you Dr. Sonu Gand.
Thank you for actually talking on this topic, because it is a challenging and complex topic. My name is Sonu Gand. I'm a psychiatrist. I'm chief of psychiatry at Humber River Hospital in Toronto, and there I also am the physician chair of our MAID team, which is the Medical Assistance in Dying team. I've also been involved in the area of policy related to MAID since it first came about in Canada in 2016, because at that time I was president of the Canadian Psychiatric Association. And as policies were evolving, I did a lot of consultation with members and others about kind of what sorts of policies might make sense.
Gotcha. And is this going to be something that Canadians will soon have an option for? Is it in 2023 they're planning on passing something this?
Yes, so the background is that in 2016, which is when we first started with our assisted dying laws, and that's also, by the way, when the term medical assistance in dying was coined. That's a term that came up in Canada in that context.
Oh, okay.
So in 2016, when the laws came in, there was a safeguard initially in place that required natural death needing to be reasonably foreseeable. And that safeguard was challenged in a Quebec case, Truchon case in 2019. And in that Quebec case, the safeguard was overturned. It was ruled on by a single judge in Quebec, and she felt that that safeguard was overly restrictive and that it violated our charter. And in response to that, the government, by the way, did not appeal that case, which is pretty unusual. So they did not appeal the provincial case to the Supreme Court, but instead they brought in what was called Bill C7. And when they initially proposed Bill C7 in early 2020, the earlier drafts actually had an exclusion for sole mental illness conditions, meaning that for MAID, there are a number of things that need to be present to potentially qualify. But the fundamental thing is the presence of a medical condition that's deemed grievous and irremediable. Irremediable meaning we can predict it won't get better. So in the first few years, when the original legislation came in, because that safeguard of naturally foreseeable death being there, because of that, sole mental illness conditions typically would not qualify at that time, because mental illness in and of itself doesn't tend to lead to foreseeable death. Mm-hmm. Once that safeguard was going to be eliminated, then in 2020, as I was mentioning, the government initially put in an additional safeguard that would have been there to say that people would not be able to get MAID for sole mental illness conditions. So it didn't mean you couldn't get it if you had mental illness. You could have mental illness and another condition.
Right.
And you always could get it for that. But for mental illness alone, with that reasonably foreseeable natural death safeguard falling, the government initially had that additional safeguard planned. And then suddenly in 2021, they reversed that position. And in 2021, when Bill C7 was actually passed, they reversed the position and said, we're going to put what's called a sunset clause of 2 years. So for 2 years, you still would not be able to apply for MAID for sole mental illness. But by March 2023, the sunset clause says people will be able to.
I see. Okay. And what are your feelings on people having that as an option with a mental illness? I'm assuming there's going to be some kind of guidelines as to who can and can't use MAID for sole mental illnesses.
So, it's a complex area because on the one hand, people with mental illness have faced stigma and discrimination for years, decades longer. Mm-hmm. And we have rightly pushed against that stigma and discrimination and said, look, mental illnesses are as valid as any other illness. They cause a lot of suffering. You have to take them seriously and treat them with equity. Mm-hmm. The challenge is that when we're talking about people who are seeking death, people seek death for all sorts of potential different reasons. And it's one thing when somebody is seeking death because they have, say, a terminal illness and they're facing suffering from, pain and deterioration that's not going to resolve. Mm-hmm. It is something else when somebody is seeking death in the middle of a deep depression, where part of the depression symptoms themselves says to the person, I'm never going to get better. The future will be terrible and the world is terrible.
I've been there.
And this is the thing, that anyone who has struggled with depression knows that how they think in those periods of time is different than how they think in other periods of time. And so the whole issue of, it's interesting that the issue of assisted dying in Canada has very much been framed as, oh, it's about autonomy. It's about your, right to make a decision and choose. With mental illnesses, the decisions we ourselves make change. And when it's a decision that's saying, well, I don't want to be here and I want death, and we know that's a symptom of illness, obviously there's, many layers of complexity there that are different. But to me, the fundamental thing is, and I've wrestled with this because I'm not what they call a conscientious objector. I actually, as I mentioned, I am the physician chair of our MAID team in the hospital. I wouldn't do that if I was a conscientious objector.
Right.
So, I've seen the value and benefit that MAID can bring in appropriate situations. It has also sensitized me to the very real dangers of MAID in inappropriate ones. And so to get back to your question, I actually have huge concerns about MAID expanding to sole mental illness, because the way we have framed MAID is that it's meant for a medical condition that we can predict is irremediable. A medical condition that we can predict will not get better. And the reality remains that we cannot make those predictions for mental illnesses. Every expert group that has looked at this, including CAMH, right, probably our most kind of a world-renowned, esteemed, apolitical medical organization, they have concluded that there is not enough evidence, not enough ability to predict when a mental illness will not get better in any individual case.
Right.
So when you put all that together, that the symptoms of illness itself might fuel a wish for suicidality. And the evidence also, by the way, we'll hopefully talk about this a bit later, but the evidence shows we can't distinguish suicidality from people who are seeking psychiatric euthanasia. And again, that's different from people with terminal conditions. But when people seek it for mental illness, we actually cannot distinguish that from what are traditional suicidal wishes that people benefit from suicide prevention from. So when you lump that together with also, we can't even predict the illness won't get better, and that's what MAID's supposed to be for, then what are we providing MAID for in those situations? That's the concern, because we will provide it to many people who would have improved.
Right. Yeah, I mean, psychology itself is still a fairly young science. It's, it's hard enough to get a proper diagnosis sometimes, let alone know whether or not the diagnosis is going to be irreversible and it's going to or get worse. Yeah, when I think there was an article in the paper about a month ago about this, and well, that's how I got your name. And yeah, there was a lot of red flags came up for me because I'm a mental health advocate. I've had problems. I've attempted suicide and stuff. And yeah, it was like, but I got better. When you get married, you have to be of sound body and mind just to get married, let alone trying to decide whether or not you should die.
Mr. Renbaum, that strikes such a chord with me, because this is precisely what and we know this will happen. We know that people in those moments of transient despair, they will make these decisions. And we will, and this deeply concerns me from a professional level, because then some of my colleagues will, in those assessments, say, oh, I don't think this can get better. And that person will get made. And on top of them getting made as a permanent solution, so-called, to their transient despair, a lot of times that despair is also fueled by all sorts of other life suffering, psychosocial suffering, poverty, loneliness, especially in mental illnesses.
Mm-hmm. Yeah, I was
And
reading
so
your
we
paper
will
on
have,
this.
pardon me?
I was reading your paper on this, actually. Anyway, I just wanted you to know I did some research.
There, there, there was a headline in the UK Spectator. This is getting international attention, as it should. I think people are alarmed at what's going on in Canada. And I actually think most Canadians are not aware fully of what's going on and the implications. But there was an article in the UK Spectator, and the headline was, "Why is Canada euthanizing the poor?" Chilling headline.
Interesting. So we're not, I mean, other countries have done this or are doing this. Do they have different policies as to how to decide?
They do. Now, the only countries in the world right now that actually are providing psychiatric euthanasia, in other words, made for sole mental illness, are a few of the Benelux countries in Europe. And so we do have some data from Netherlands and Belgium where this has been happening for a few years. That data does raise concerns. The evidence there does raise concerns. And in terms of the rules, you were mentioning, do they have different procedures? They actually have more safeguards than we do. Canada now is poised on having the fewest safeguards in the world for this. The reason I say that is we have one part of our legislation that says that the suffering that the person has needs to be relievable by means the person finds acceptable. And that's understandable, right? Nobody's talking about forcible treatment or forced treatments. That's not what I'm referring to.
Right.
But when we're saying that we are going to make predictions that something can't get better, what we also are now opening the door to is making those predictions that we know we can't make in mental illness, but making them even when people haven't had access to treatment or haven't had treatments. And that is different because in every other country in the world, including Belgium and Netherlands that I mentioned, they have what's called, they term it in various ways, but basically they have requirements that the decision both needs to be well considered and the person's suffering needs to be something that is, that essentially best efforts of treatment have been made. So it's not that somebody could get there in those countries without ever having tried treatment. In Canada, you can. And we know that less than 1 in 3 in Canada get the mental health care that they need for mental illness. So that has huge implications.
Right.
And the data there also has a lot of concern because for psychiatric euthanasia, what we find in those countries is that, so let me rewind just briefly.
Sure.
One of the fallacies or misconceptions here is that because the data in Canada so far has shown that most people getting made are, they actually come more from privilege. So the researchers find that they have more education, higher socioeconomic standing and privilege, and in the researchers' words, tend to be white. Now that is before MAID expansion. That is for MAID when death is foreseeable. And that bears out in other research for terminal MAID, that when people are seeing the end of their life and trying to relieve some suffering that's unavoidable at that time, it often is about people wanting to preserve autonomy and dignity. And it often is people who've had a chance to live a life with dignity. When you expand it to psychiatric euthanasia, when you expand it to MAID for sole mental illness, that association completely flips. And what we then find is that people actually have unresolved life suffering, like loneliness, like poverty. They feel a burden to society. Those are some of the things that are fueling the MAID requests. And absolutely terrifyingly for me as a psychiatrist, you also then find a gender gap emerges of 2 to 1 women to men who actually seek and get psychiatric euthanasia. And the reason that's a terrifying number is that that parallels the same ratio of 2 to 1 women to men who attempt suicide. And most people who attempt suicide do not complete suicide. Most people do not die by suicide when they attempt it. And most who attempt it do not try again. And so, if somebody recovers, they don't try again.
Right. Yeah. And I mean, I consider myself somewhat recovered. Of course, I still have lots of anxiety and I may relapse once in a while, but even a few weekends ago, I spent a night in hospital because of suicidal thoughts, but not suicidal idea. I wasn't like compulsed. I wasn't, I was having a panic attack. And what you're saying about people with mental illness and like, sorry, there's so much here. So what I'm trying to relate, when I was in my darkest hours, I had no business making life and death decisions for anyone, let alone myself. So to say that someone in that state has the option of MAID, it's almost counterintuitive, and to say even modalities, therapy modalities, and things that I don't, we've tried everything that I feel like trying. I mean, give it another year, then I felt like trying those other things. It's almost like an addict relapsing and relapsing and relapsing, but sometimes they have to go to treatment 5-6 times before it starts to work. So it's like an addict after one time in treatment says, no, I've had enough. I want to be MAID. I don't know. I'm kind of all over the place. This is very complex.
No, but listen, I think you're actually hitting the nail on the head there. That's not at all over the place. It's very powerful, because what you're pointing out is that in a state like that, when we then enable someone to have an easier and quicker death, what are we doing? Because we framed MAID as something that's meant to be compassionate, to provide relief from suffering. Mm-hmm. I think there's a difference between making something so easy that it's, between compassionate and relief from suffering, but there's a difference between that and abandoning people. Mm-hmm. And in my opinion, this is why I got into the field. It's not for imposing my view or any other person's view on someone else. It is to stand with somebody else and stay with them so that they can actually get better and then regain their own will to live. And the story that you're saying reflects that so much, right? And it's not just one person, it's also everyone that then becomes part of your family that wouldn't otherwise exist, and all of that. This has huge implications. Mm-hmm. We know that when we make things easier for people, more people do them. That's
right.
Kind of it's an obvious fact, but what people might not realize is that also applies to suicide. Right. When suicide is easier, more people actually complete it. It's hard to change national suicide rates, but we have a few examples internationally where it has happened. For example, in the UK, the suicide rates were quite high when they had essentially carbon monoxide was piped into homes for the coal gas stuff. And when they changed that, so it was no longer carbon monoxide, which is highly lethal. When they changed that, the national rates fell by about 30%, I believe it was, for men and women.
Wow.
And we've had similar changes with countries in Asia where suicide deaths are commonly done and have been commonly done by pesticides. When they reduced the toxicity of pesticides, the suicide rates nationally in countries fell. So what does that mean? Does that mean that people are now wanting to live because you've changed carbon monoxide amounts? No, what it means is we have made it a little bit harder to do something that previously was much easier to do. Now with MAID, we're actually providing something that's presented as, we're going to relieve your suffering. We're going to make it easy and painless,
Mm-hmm.
And we're going to do it at a time when you're in the worst time of your life, in a period of despair, and offer it to you. Do you want it?
Yeah. It's
That's
like,
chilling.
it's, people seeking help when they're having suicidal ideation. It's just, you may as well just say, well, go ahead. You know what I mean? It's well, why are we trying to stop people to commit suicide then? Because it seems like you're actually helping them commit suicide.
So a couple of, and it's interesting. I don't mean to say this in a negative way, so please don't take it that way. But even
No, no.
the language, it's funny how we've come and framed this, because even the word commit implies that the person is doing, something wrong. We talk about
Right.
committing a crime or something.
Mm-hmm.
And with suicide, I would actually say that it's something that the person, they're responding to a state of suffering. They are. And I don't think they're committing a crime in that sense. They are actually responding in a state of suffering when they can't see anything other than ending their lives to stop that suffering. But that also is in a state of hopelessness. They can see no future. In fact, literally, with depression, we know that there are brain changes that make it hard to see a future. But in terms of what we're then facilitating, in my opinion, what MAID risks doing when we falsely tell people, oh, your mental illness will not get better, and we can't know that, but we're telling them your state of suffering can never get better. They have a state of hopelessness and despair in that.
Mm-hmm.
And we're then saying, well, here could be a way of relieving your suffering. That is facilitating and not helping. To me, that is facilitating suicide, actually.
Right. And I was reading, I can't remember if it was in the same paper that you had wrote or not. And this is kind of contradictory to what we're saying. A lot of people, when given the option of MAID for mental health issues, they actually start to get better. It's almost like a reverse effect. It's like, do you know what I'm talking about? That data.
I do. And what it signifies is that when people feel they have options, they also then can feel they have some hope.
Right. Right.
And in the context of MAID, again, it's a kind of bizarre dilemma, dichotomy type of thing, because if what we're saying is you can't get better, and because your suffering can't get better, that qualifies you for MAID. But then you quote unquote, get qualified for MAID and you feel better and you get better. What does that mean about whether their suffering could or could not have gotten better? What it means is that a significant part of what could have helped them get better was something psychological, something where we're providing either hope or options or validation of, yes, you are suffering terribly. Let's see how we can help you with it. But all of those are psychological things, which then, the proof is in the pudding.
Yeah.
If the person feels better because they've now been given an option for something, what it means is psychological things are what could have actually helped them. And instead, we're going to provide some of them MAID.
So by offering them MAID, they're saying there's no more options for you to get better, but then they end up starting to get better, so that they just prove to themselves that they were wrong, that there actually was options to get better.
Exactly. And yet what we also know is that some people will proceed and actually get MAID. And, part of this, there's all sorts of other dynamics at play, because when a medical practitioner says, I think you're never going to get better, in other words, this is irremediable, that also carries a psychological impact on someone. Someone then actually internalizes that and says, oh, it's not just my depression telling me, it's now my doctor telling me.
Yeah, I'm
so
truly
I guess
hopeless.
I'm never going to get better.
Yeah.
And the reality is, and this is part of what's so disturbing to me, the reality is that scientifically, we cannot do that in mental illness. And by the way, it's completely different from other medical conditions that MAID is provided for. People will often say, well, you can't make predictions about anything. And, you can't make 100% prediction in medicine about anything. There's a world of difference. When you have advanced cancer, The spontaneous remission rate from that is estimated at like less than 1 in a million type of thing. When you have depression, the spontaneous remission rate, meaning even without treatment, within 3 months, 6 months, and a year, you have increasing numbers of people spontaneously getting better, on the order of about 30% in sort of each of those categories. Well, actually, the numbers are a bit different, but you have a significant number of people spontaneously improving with no treatment even. So it is different from other medical conditions that are a lot more predictable. We don't even understand the underlying biological basis of mental illnesses. How are we making these predictions that things won't get better? Especially when a lot of that suffering is fueled by life suffering as well.
Do you think it's that MAID could be used for certain people with mental illnesses? I mean, I'm not saying it would be easy to predict, but there are, scenarios where maybe that should be an option.
So I think that if society wants to have that debate or discussion, it should have it openly and honestly. And if the debate was, well, do we think that somebody who is suffering from anything, whether it's mental illness or anything else, do we think that there should be some sort of threshold that if they've suffered enough and these other conditions are met, should they qualify for MAID? That's not the discussion we've had. Premise and the promise of MAID, as I was saying before, is that it is only for when a medical condition is grievous and irremediable, predictably can't get better. So mental illnesses absolutely can be grievous, but it is actually, in my opinion, it's actually misleading, even a deception, to say we can predict them as being irremediable. And so if that's what the MAID framework is for, then I don't believe mental illnesses could or should qualify, because you cannot make that prediction in any individual case. And, CAMH and many others have told us that. Strikingly, by the way, you asked earlier about safeguards and protocols. There was, as part of the Sunset Clause legislation, one of the things that was also to happen was a federal panel to provide guidance on protocols and safeguards on how to provide MAID for mental illness by next year. That federal panel report has now been issued. It was supposed to come about, I think, sometime in March. They sought an extension and they were given it, so it was released in mid-May. And I have to say, I was quite surprised, because even, firstly, that panel wasn't charged with saying should MAID for mental illness be provided. They were kind of tasked with saying it's being provided, just tell us how to do it. And the panel, I have to say, I was actually dumbfounded, because they conclude that as MAID is expanding for sole mental illness, and this is a quote, that in their opinion, no further legislative safeguards are required. They literally say that. And in terms of the guidance about, well, how do we decide when something is not going to get better? This is what they actually say. They say that it is not possible to provide fixed rules for how many treatment attempts, how many kinds of treatments, and over what period of time, that was all in quotes, that treatment should be required essentially before providing death by MAID for mental illness. And they recommend the decision be made on a case-by-case basis. And that was how they concluded how people should predict incurability or irreversibility of mental illness. So in other words, no guidance whatsoever, no standards. We actually wrote so I've been involved with a group from 2 years ago and also more recently called the Expert Advisory Group on MAID, EAG on MAID. And we wrote a brief on this because we were so concerned about the lack of guidance being provided. And basically what that does is it exposes people to arbitrary and unscientific assessments that are based on the ideological values of assessors That's not science. That's not medicine. And so, in that context, no, I absolutely couldn't support MAID for sole mental illness because it wouldn't actually be provided, in my opinion, for mental illness. In many cases, it's going to be provided for life suffering. We know that marginalized people with mental illness are particularly at risk. So, what are we providing MAID for in those cases?
Well, here, like I'm in Saskatchewan, here in northern Saskatchewan, there's people that don't even have access to psychiatrists, let alone other mental health modalities. So I mean, their options are really low. It's like, well,
Yes.
I tried talking to a counselor over Zoom, and it didn't work. So that's all the options I have. I might be exaggerating a bit, but so then, according to the quotes you just read, they've tried everything they can within their, within their means. So then the next option is MAID.
Look, we've had cases. We've had cases like exactly on what you're saying. I done a podcast last year on Canada Land, and that was interviewing as well people in our country who were saying, "I die when I run out of money."
Right.
And in terms of the treatment issues, we actually have now had, and this may be a world first, I'm not sure. It's been reported on in the media, but we've had somebody get MAID who had multiple chemical sensitivities and wasn't able to get adequate housing that might provide a safe environment that didn't trigger all of those. So one person actually got it in those circumstances. There is another person who applied and was approved for it. And when that got out in the media, fortunately, they were able to get some financial assistance. People actually poured in out of generosity. And that person was able to move elsewhere and is feeling much better and saying, it's actually, I don't want MAID. And in fact, it shows that the person, even when they're seeking MAID, it's not that they want MAID, they don't want death. They just don't want that ongoing life suffering. Mm-hmm. And so the lack of any of these even both evidence and standards, the lack of that being provided by this panel was deeply troubling. Actually, two people, the panel started as a panel of 12. Two people resigned from that panel before the report came out and did not sign off on the recommendations. If you do want to read more on some of this, that group that I mentioned, we actually do have the report, our brief up on the website. It's www.eagmaid. So eagmaid.org. But it shows the lack of standards and some of the dangers that can come with that.
So who made up this panel? Is it politicians? Is it doctors? Is it?
It was a panel that was appointed by the federal government. And so there were a number of different clinicians and psychiatrists and others on it. And again, that would all be on their website report as well.
I'm actually a little surprised. I thought that you were kind of on board with MAID for mental illness, but you had, you saw some red flags in the Canadian system with it, and so I'm a little surprised that you actually are like completely anti-MAID when it comes to mental illness, because it hasn't been proven to be I can't say that word.
Irremediable. Yeah.
Yes, thank you. So,
Well,
hi, everyone. Just a quick break here to tell you about a couple wonderful podcasts that I think you might like. If you enjoy mental health podcasts, which I assume you do because you're listening to this one, then I think you should listen to the Rainy Days podcast. That's with host Jason, and he was even a guest on my show here not too long ago. Jason aims to discuss and explore mental health unapologetically through shared living experiences and projects centered around mental health and well-being. Jason's a great guy. He's got great guests. He talks all about all types of things mental health, and he's from the UK, so he talks real fancy like, so I think you'll like that. That's the Rainy Days Podcast. Another amazing podcast is a Sober Story podcast with your host, Emily. She is also an amazing host, and she also has amazing guests. There's a powerful story behind each person's journey to sobriety. Join us each week to hear the stories of people from all different walks of life as they share how they became sober. And I'm telling you right now, as someone who's been sober almost 6 years, it's true. I have yet to meet someone who does not have an interesting story about how they got sober. So, the Rainy Days Podcast and a Sober Story podcast. Check those out. Write and review them.
I should clarify. I mean, I've struggled with this, right? I mean, when I started and was trying to understand better what will people be seeking MAID for, what are the appropriate situations, etc., I didn't come into it with any particular ideological view other than I think we should be guided by evidence and know what we're doing.
Right.
And so in terms of whether I'm even opposed for MAID for mental illness, it's something where, again, it may depend on how it's framed. And because it's framed as it's for a condition that can't get better, then I believe it's dishonest providing MAID under those circumstances.
Right. Okay.
If it was a different societal debate that, oh, you know what, again, has this person suffered enough? Not to put a judgment on it, but in whatever we're saying is enough from a perspective of standards. And in that situation, they should be able to get MAID. I don't know. I mean, maybe I'd feel differently about it, but from what I've seen, I'm getting increasingly concerned about who would seek it for psychiatric euthanasia. And that's what the European data shows. And that's what's really driving my concerns.
It's interesting that I think a lot of mental illness is irremediable. Did I say it right?
Yeah. That's
that it is irremediable if they're stuck on a reserve, or they're stuck in poverty, if they're stuck with no supports around them, then yeah, I mean, it is irremediable. But you just mentioned that, as soon as some people got better housing, got different, a little money, then more supports, then all of a sudden, people start to, recover. I'm so glad that you mentioned that, because we so often frame things like both mental illness, but also even suicide as just about mental illness. And in many cases, it is, if somebody has mental illness, they are at a higher risk of having suicidal thoughts. That's part of the symptoms of some of our mental illnesses. But in other situations, like poverty, like housing, then a different pattern emerges. And this is why, and this is not just unique to Canada, by the way. Every country that's studied this for First Nations and Indigenous populations finds the same association, that the suicide rates of First Nations and Indigenous people are way higher than the general population suicide rates. In Canada, they're about 3 times higher, and even higher in some specific situations, like if somebody is on reserve versus off reserve, and for Inuit populations, even higher. And that's not about mental illness. That's about social disenfranchisement. That's about intergenerational trauma. Mm-hmm. And what it shows is that that kind of suffering can fuel suicidality. And that's even before MAID, right? That's right. Kind of suicidality without making it easier. And with MAID, when you factor MAID into those equations, then what you're also saying is we're sending a message that society accepts MAID could be an answer to that suffering. Yeah, that's, I don't know. Is it almost a form of, well, like the UK Spectator said, are we targeting the poor? Is it, do you think, is it ideology, or is it more menacing than that?
Well, I can't comment on motivations. It's not that. So, I'd hesitate to say the word, that we are targeting. However, will the poor be targeted in terms of how these policies play out? Yes, they actually will be. You know, I've got to pull this up actually because it's a really good quote, but maybe I won't be able to find it in time. But in terms of the targeting, again, I'm not suggesting this is conscious targeting, but policies can still have a targeted impact, even if it's the same policy for everyone.
Mm-hmm.
And that's what this MAID stuff actually, I think, does, because it does expose people who are non-dying and disabled and marginalized to societally assisted death. And that is very different than somebody who, you know, has had a chance to live with privilege.
That's right. Yeah.
And so I actually do see that, and I've written about this. I do see this as essentially, on the one hand, the expansion of MAID, how widely we're expanding it now,
mm-hmm.
it may provide some people increased privileged autonomy. Mm-hmm. Those of us who've had a chance to live with privilege, it may provide them increased privileged autonomy. But for other marginalized groups, it's not about autonomy. It exposes them to avoidable deaths. And in that context, I think we also need to understand and recognize that providing MAID is a lot less expensive than providing care. You know, the Parliamentary Budget Office even costed some of this out, and that won't even capture all of this cost savings, because providing MAID is obviously a lot cheaper than providing medical care. But when you also factor in that people who are not dying, who may be 20, 30, 40, they'd have decades left to live, but they might need supports to live a dignified life if they're disabled. So that is a significant cost saving, actually, over time. Now, again, I'm not saying that anyone's, consciously doing this, but I also think it's irresponsible to ignore that, because we know that our financial system, our health system, is under constant pressure and strain. And any kind of levers financially also may have subtle influences, even if they weren't intended.
Yeah, it is so frustrating when I hear that, especially when it comes to the financial part of it, because again and again and again, I keep hearing that investment in mental health it's actually an investment. The more you spend on mental health, actually, the less you spend on social services and things like that. And it's actually good for the society and the government if you just invest and give supports to people that don't normally have it. And I could say the same thing even when it comes to like safe injection sites, things like that. It's actually cheaper to fund a safe injection site than it is to put people in jail, to send ambulances out to people overdosing in the streets, and yet again, they go the other way. So it's actually cheaper for society and the government to just support people.
Yeah, and so what it shows is that the we if we take too simple definition of equity and think that, that means everything has to be the same. Mm-hmm. That's not equity.
That's right.
Equity isn't about everything being the same. It's about understanding how things affect people in different ways. And the quote, this actually was in that UK Spectator piece as well. They did quote this, but it's from a French poet, Anatole France. And it goes, "The law, in its majestic equality, forbids the rich as well as the poor to sleep under bridges, to beg in the streets, and to steal bread." Pointing out that, you're probably not going to have too many rich people who are begging in the streets. And so the idea that the law is equal for everyone, no, it impacts people in different ways. And especially if you've had a life where you've always been marginalized by society and there's all this other suffering. And so I actually think that if that poet was alive today, so the ghost of Anatole France, I think what he's saying about Canada's Maid laws would be that Canada's Maid law, in its majestic equality, helps the poor as well as the rich to die for life suffering and poverty.
Well, you've seen the image of people trying to look over a fence.
Yes.
Equality is that they all get the same size box to try and look over the fence. And of course, the tall guy can see over the fence. The short guy still can't. So that's not equality. Equality is giving the shorter guy a taller box to stand on to look over the fence. And yeah, I agree with that poet and you. However, a lot of people just think about me, right? I don't know if it's a new phenomenon or not, or if it's just the way humans are. They seem to care less about the greater good of humanity, and they just worry about me today, right now. And yeah,
I think there may be ways of kind of getting at that, because I think that part of what allows that to happen is that we sort of accept a false narrative about what this is about. And people have been sold the narrative that, oh, this is about your autonomy. When we actually kind of let people see what's really going on, I think a lot of people get uncomfortable with it. This is, by the way, part of what really troubled me. I think a couple of weeks ago, our prime minister was asked about the expanding Maid laws in the House of Commons, and he essentially defended them. And that, to me, was very troubling. But in terms of getting people maybe aware and understanding what's really going on, I think maybe shifting the question helps with that, because the way I've come to see it is that, when this first started, I had thought that, maybe there's a way to perfectly define, here's who we think really should be able to get it for reasons we think are quote unquote, valid, that society would think makes sense. And here are people who we don't think should be able to get it. And thought that maybe there's some sort of perfect balance, right? Where do we want that perfect balance or that line? I don't believe that's possible, because especially as things expand, especially as you expand it beyond end of life circumstances, then all sorts of other factors come into play, including, what we've talked about, life suffering, lack of predictability of the illness, all of that comes into play. And so then the question becomes different. The question becomes, which mistakes do we want to make? Do we think that we should set a threshold that says that in some cases, some people who maybe we think should be able to get it, but we're not going to provide them death? Or do we think the mistake should be in the other direction, that, we know that there are some people who we absolutely think shouldn't get it for these reasons, but we will still let them get it and provide them death because it allows others to get it more easily? So it changes the question, and it gets to an even more pointed question, which is, how many wrongful deaths are too many? In my opinion, one.
I guess maybe that's why they made it a case by case. Like there is no threshold. They make it go case by case. So I don't know. But that's about the only saving grace I see in this policy.
Well, that's actually not I don't think that's a saving grace. That's problematic, because what it means is there are no standards even being applied. Normally what you would want is you would want policy informed by evidence. There's no evidence that helps guide this policy. In the absence of that, you would at least want there to be some standards, so you know that people are kind of doing similar things and they know what to expect and you know what they're doing. And now the panel has failed in providing even any standards. And here's some of the danger of that. Before our original Maid law came in 2016, there was a period of time where people were able to get Maid on a case-by-case basis based on legislative review. So before while the laws were being drafted, the government and courts were allowing people to apply for it on a case-by-case basis. During that time, there is one person who did get Maid for a sole mental illness. Their condition is what was called conversion disorder at that time, meaning they had physical symptoms and we didn't know what the physical or medical cause was. So that's categorized as conversion disorder.
Mm-hmm.
This is all on public court documents, by the way. The psychiatrist who weighed in on that case and did the assessment of irremediability, so he said that this person's conversion disorder of unexplained physical symptoms will never get better, so it's irremediable. And she also has capacity. She's competent. She's legally able to have capacity to make this decision. And she got made. I think she was in her early mid-40s. That psychiatrist, this is to show you the problem with lack of standards. That psychiatrist never even spoke with this person, never spoke with the patient, based his opinion on a chart review. That's documented in the court documents. Now, I don't know how you can base an opinion that somebody is capable, is competent, has capacity without talking to them.
Right.
It's beyond me. I've worked in this field for a number of years. I don't know how you can make a decision of competence without talking with a person.
Huh. So you've never done that?
With lack of standards.
You've never read a piece of paper and been like, okay, I know everything about this person now?
Well, I hope not. I kind of hope not. I think we all have our, uniqueness and life stories. And if we really want to understand that, it's like, I'm not going to say, oh yeah, I know you from reading a chart.
That is concerning. This is concerning. Well, let's figure this out. Let's hash this out. We got 5 minutes. What do you think? How are we going to solve this? Have a standard for one.
I actually think that the country needs to take a step back and revisit this whole assumption that MAID for sole mental illness will be offered in 2023. I don't think it's responsible to do that. I think that there needs to be more unbiased and evidence-based work done on it. There is no rush to start taking the lives of non-dying disabled who will get better and taking their lives in periods of their life despair. So in the absence of that, no other safeguards actually mean anything.
I suppose. Yeah, you're right. Like, look at the case you were just talking about. Like, they don't even know why she is sick. So how can they predict that she will even get better? And then to decide that she's of sound body and mind to make decisions. And is that the only case in Canada so far that has sole mental illness had MAID?
So there were people who testified in the parliamentary hearings that there have been some other cases, but it's something where for sole mental illness, because of that sunset clause and because before the reasonably foreseeable death safeguard, it certainly wouldn't be widespread. And I don't know the circumstances of those other cases that people said have occurred.
Gotcha.
What we do know is that people in the disability community are seeking MAID and getting MAID for all sorts of life suffering. And so that's even for other conditions outside mental illness.
So for mental illness, we'll just say that case you were talking about is kind of the standard because that's the first one kind of past the sunset clause ish.
Well, I think it shows the dangers and risks of where we're going with this.
Yeah. So if that's kind of the first well-known one, then to me that's the standard. So all other ones will be compared to that one, and that one sounds like not very well planned, thought out, and disturbing. So,
but listen, I know this is really serious stuff, and I do think there is hope. I really do, because I firmly believe that the way things have expanded has largely happened without people being fully aware of what's going on, right? I mean, it's also happened through COVID and all of that. And what we are finding, and not just me, I mean, many of my colleagues are concerned about this. And as more people are speaking up about it, the public also that hears about this does have legitimate concerns as well. And so stuff like what you're doing with your show and other public education, I actually think that that is not just important. I think that that's the answer. That's what's helping raise awareness of it and hopefully put some brakes on something before we totally go off a cliff.
So if people are concerned, who can they talk to? Who can they reach out to let them know? Is it their politicians or or not MLAs, MPs or?
Yeah, it's interesting because this is a federal law that's coming into play. The provinces will, so whether it's the MP, the federal parliamentary MP, or whether it's the provincial one, both may actually have a role. Because although it's a federal law coming into play, Quebec, very surprisingly, by the way, because Quebec has been at the forefront often of some of the expansions. But back in, I think, December, there was a Quebec commission that reviewed things, and they recommended against expanding it to mental illness. That took a lot of people by surprise because Quebec had been before more expansive. But that panel recommended against that. And just a few weeks ago, Quebec actually tabled a bill that said MAID expansion will not apply for mental illness. They've tabled that bill.
Oh, okay.
I don't know how that plays out, if there are differences between the provincial stuff and the federal stuff. But in terms of people's input and raising their concerns, I think both the provincial and the federal parliamentarians, I think they need to hear it.
Right. Yeah. Because so it's a federal decision, but each province is kind of autonomous, has its own health systems and will have their own panels and things to decide whether or not how their province is going to deal with it.
Yeah, we don't fully know.
Yeah. Interesting. Is there anything else you wanted to add to this before we go? I think you've answered all my questions until I listen back, and then I'll have about 50 more.
No, nothing to end. I always learn things with the questions as well, because they bring out what people's circumstances really are. So I wanted to thank you for kind of having both interest in the topic and also with what you shared, because I think it really demonstrates the kind of the real life implications of some of this. And I think people need to know that.
Thank you so much for that, Dr. Gand. This interview kind of blew my mind a bit. It was very enlightening and very, worrisome at the same time. I can't express my appreciation enough for Dr. Gand for coming on and kind of educating all of us about this. So again, it's a very important subject, very real subject. So please rate and review, share. I think this is a very important episode. They're all very important episodes. People always get stuff out of the episodes, but this is a pretty important one. I can't thank you enough, Dr. Gant. So anyhow, next week I am speaking with Emily Roberts about her addiction issues and big liquor companies targeting women. So stay tuned for that. Rate and review.
Thank you for listening, and please subscribe, rate, and review however you are listening to this podcast. It only takes a moment, and it really helps the show out with getting noticed. This episode has been sponsored by Penny University Bookstore, 3104 13th Avenue. Call 639-571-2186 and check out their online bookstore at pennyu.ca. The Saskatchewan Podcast Network is supported by Connexus. Wellness, however you define it, is achievable. You don't even need to figure it all out by yourself. Talk to Connexus. They'll give you guidance, motivation, and the push you need to reach your goals. They've got you. They're your financial partner, and they know you can achieve your very best, your financial best. Prove them right. Start right at Connexus Credit Union. The Saskatchewan Podcast Network is also sponsored by Direct West. Are you a business owner looking for new avenues to promote your business? Direct West digital billboards are a great opportunity to highlight a new product, new promotion, or anything else you'd like your customers to know about. You can get local, expert marketing help for your business at directwest.com. If you are having a mental health crisis, please call the Canadian Crisis number at 1-833
306-456-4566. In Saskatchewan, the mobile crisis team in Prince Albert is 306-764-1011. In Regina, it's 306-525-5333, and in Saskatoon, it's 306-933-6200. Don't forget to check out my children's book, Sometimes Daddy Cries. Sometimes Daddy Cries is told through the eyes of a boy whose father suffers from depression. He sees his dad get sad, rest, and even go to the hospital, all while comparing his father's depression to a physical ailment. Available on Amazon.ca. I'll see you next time. This is Todd Renabaum saying, make your beds and take your meds. Bye.